Chapter 36 of Apurba Sastry Essentials of Microbiology, which is Viral Leishmaniasis and Trypanosomiasis. Chapter preview. In this chapter, we will be previewing viral leishmaniasis, Chagas disease, and African sleeping sickness. Introduction. Hemoflagellates are the flagellated protozoa that are found in peripheral blood circulation. Examples include leishmania and trypanosoma. Both are transmitted by the bite of insect vector. They have an oval to elongated body, nucleus, and a single flagellum arising from kinetoplast. Kinetoplast represents multiple copies of mitochondrial DNA. The intracellular portion, root of the flagellum, is called as the axoneme. Based upon the arrangement of the flagellum, they exist in four morphological states. Amastigote form, round to oval, lax flagellum. Promastigote form, lanceolate shaped, kinetoplast is the anterior to nucleus and flagellum arises from the anterior end. Epimastigote form, elongated, kinetoplast is placed close to the nucleus, flagellum arises from the lateral side and traverses the body as a short undulating membrane and comes out from the anterior end. Trypomastigote form, elongated, kinetoplast lies near the posterior end, flagellum arises posteriorly and runs as a long undulating membrane. In leishmania, amastigote and promastigote forms are seen. Amastigotes are the diagnostic form found in man, while promastigotes are the infective stage to man found in insect vector. In this figure, we can see the various morphological forms of flagellates. First is amastigote without any flagella. Second, promastigote. Third is the kinetoplast containing epimastigote. And fourth is also with kinetoplast and an undulating membrane, that is the trypomastigote. In trypanosoma, epimastigote and trypomastigote forms are seen. In man, trypomastigotes are diagnostic form. In insect vector, both epimastigote and trypomastigote are found, the latter being the infective stage to man. Leishmaniasis. Leishmaniasis is caused by an obligatory intracellular protozoa of the genus Leishmania, which primarily affects the reticuloendothelial system of the host. Vector. Leishmaniasis is transmitted by the bite of the female sandfly vector. Clinical forms. Leishmaniasis presents in various clinical forms. Visceral Leishmaniasis (VL), post-Kala-Azar dermal Leishmaniasis (PKDL). It occurs few months to years following VL. Cutaneous forms occurs in various forms such as cutaneous leishmaniasis (CL), diffuse cutaneous leishmaniasis (DCL), leishmaniasis recidivans (LR), and mucocutaneous leishmaniasis (MCL). Subgenera. Leishmania has two subgenera, Leishmaniasis leishmania and Leishmaniasis vania. Both of the subgenera comprise of nearly 20 subspecies. Old and New World. Depending upon the geographical distribution, Leishmaniasis is classified into two groups. Old World Leishmaniasis seen in Asia, Africa, and less frequently in Europe, transmitted by sandfly of genus Phlebotomus. L. donovani causes VL and PKDL. L. infantum causes VL and PKDL. L. tropica complex causes CL. Okay, cutaneous leishmaniasis. New World Leishmaniasis is seen in Central and South America, transmitted by sandfly of genus Lutzomaya. L. chagazi causes VL and CL. L. mexicana complex causes CL. L. vienna brasiliensis complex causes MCL and CL. In Indian subcontinent, leishmaniasis is an anthropophilic affecting only humans, whereas in other parts of the world it is a zoonotic disease transmitted from various animals. Visceral Leishmaniasis (VL) and PKDL are discussed here. The various cutaneous and mucocutaneous forms will be discussed in the respective chapters. The Visceral Leishmaniasis. Visceral Leishmaniasis is mainly caused by the Old World species Leishmania donovani and infantum, together known as Leishmania donovani complex, and also by the New World species Leishmania chagasi. L. donovani is the most common species causing VL. It is found in India and Africa. It was named after Sir William Leishman and Sir Donovan, who simultaneously contributed to the discovery of the parasite in a patient from Kolkata and Chennai, respectively, in the same year 1903. The subsequent discussion in the chapter is confined to VL due to L. donovani. The differences from VL due to L. infantum and L. chagazi are described in the table. Epidemiology of VL. Leishmaniasis is an endemic in 97 countries. Most of them are developing countries of tropical and temperate regions. world, about 50 to 90,000 new cases of VL occur worldwide each year, out of which more than 90% of the cases are from three regions: Southeast Asia, India, Bangladesh, and Nepal; East Africa, like Ethiopia, Sudan, and Kenya; and Brazil. India is one of the worst affected country. In 2019, about 3,139 cases of VL and 821 cases of PKDL have been reported from India with nil death. Maximum cases were reported from Bihar, 76% of VL and 52% of PKDL, followed by Jharkhand. Life cycle of Leishmania donovani. L. donovani completes its life cycle in two hosts: vertebrate host, man, dog, rodents, and invertebrate host like female sandfly of genus Phlebotomus argentipus. Infective form: promastigote forms found in alimentary canal of the female sandfly serve as infective form. Mode of transmission: by the bite of infected female sandfly, discharging promastigote infective forms into the skin of man. Okay, now in this figure we can see the life cycle. Starting from promastigo, man and other hosts acquire infection by the bite of female sandfly, discharging promastigotes to the skin. These promastigotes transform into skin macrophages to form amastigotes. Amastigotes are carried in circulation, invade the RES, the reticuloendothelial system, then released into the blood. Sandfly takes up amastigotes while feeding on infected hosts, transform into promastigotes in the gut, and finally form promastigotes migrate to foregut, which again can infect the man. Okay, now the various forms of visceral leishmaniasis. Agent if of Indian visceral leishmaniasis is Leishmania donovani. Of infantile is Leishmania infantum. Of African is Leishmania donovani. And for the New World Mediterranean is Leishmania chagasi. Vector for Indian is Phlebotomus argentipes. For infantile is Phlebotomus perniciosus. For African is Phlebotomus orientalis and Phlebotomus martini, and for Mediterranean is Lutomyza longipalpis. Again, epidemiology of Indian is in India, of infantile is in Middle East, Central Asia, China, and Mediterranean basin. Of African is in Sudan, Ethiopia, Kenya, and Uganda. Of Mediterranean is in Central and South America. Age affected, the Indian one if affects young adults, infantile infects infants and children less than 5 years of age, African affects adults, and Mediterranean affects children. Reservoir anthroponotic infections are seen in Indian visceral leishmaniasis, anthroponotic reservoirs. Okay, zoonotic reservoirs like canines are seen in infantile visceral leishmaniasis. Uh, Anthroponotic and rarely zoonotic rodents are seen in African visceral leishmaniasis, and zoonotic reservoirs like canines are seen in Mediterranean visceral leishmaniasis. PKDL is common in Indian, less common in infantile, common in African, and less common in Mediterranean. Lymph node involvement is less common in Indian, more common aggravated by poor nutrition in infantile, less common in African, and less common in Mediterranean. Okay. In humans, promastigotes are phagocytosed by the skin macrophages where they transform into amastigote forms. The amastigote forms multiply inside the macrophages, causing the rupture, and are released into the circulation. Amastigotes are carried out in the circulation to the various organs like liver, spleen, and bone marrow, and invade the reticuloendothelial cells like macrophages, endothelial cells, etc. In sandfly, during the blood meal, the amastigotes are ingested and transformed into promastigote forms in the insect gut, which multiply and then migrate to their foregut. The cycle continues when the sandfly bites a new host. Pathogenicity. Various factors contribute to the pathogenesis of VL. The phagocytosis of promastigotes is facilitated by binding of its surface antigens such as 63 kilodalton glycoprotein GP63 and lipophosphogycan LPG to specific receptors on macrophages. LPG is the principal virulence factor, exhibits variety of functions. It prevents phagosome maturation and protects the parasite against the hydrolytic enzymes released from the phagolysosome. GPI, glycosyl phosphatidyl inositol, is a major surface protein on amastigotes, help in protecting from the phagolysosomal attack inside the macrophage. The host immune response. Depending on the host immune response, Th1 or Th2, the amastigotes are either killed or allowed to multiply inside the macrophages. Th1, T helper 1 response, when these cells are activated, it leads to a cell mediated immune response which contains the disease spread by secreting interferon gamma to activate macrophages, which in turn kill the mastocysts. Th1 response is observed in cutaneous leishmaniasis in patients after recovery treated for VL. These individuals exhibit a delayed type hypersensitivity DTH to leishmanial antigens, positive leishmanian skin test. The Th2 T helper 2 response, if these cells are activated, it leads to humoral immune response due to increased production of interleukin 10 and 4, which in turn causes polyclonal B cell activation leading to hypergammaglobulinemia. It is observed in patients developing active VL and in diffuse CL. Patients do not show positive Leishmanian skin test. The parasites are the macrophage, much like a Trojan horse. Mastocysts are released periodically by rupture of macrophages. They disseminate through the regional lymphatics and the vascular system to infect the reticuloendothelial cells of various organs. This results in remarkable enlargement of the spleen, liver, and bone marrow dysfunction. Clinical features VL. VL is also called as Kala Azar in Hindi, a term meaning black fever. Incubation period ranges from 2 to 6 months. The hallmark of VL is pentad of fever, progressive weight loss, hepatosplenomegaly, pancytopenia, and hypergammaglobulinemia. Fever. The most common symptoms of VL: abrupt in onset, moderate to high grade, and associated with chills and rigors. Typically, it is described as a double or triple rise of fever in 24 hours. Splenomegaly is the most consistent sign. The spleen may become hugely enlarged, soft, non-tender, and friable, and palpable below the umbilicus. Hepatomegaly, non-tender, moderate degree, soon follows splenomegaly. Lymphadenopathy, common is the most in most of the African endemic regions, rare in Indian subcontinent. Femoral and inguinal nodes are affected commonly. Hyperpigmentation is observed on the face, hands, feet, and abdomen, hence the name Kala Azar or black fever. It's a characteristic of the feature of Indian visceral leishmaniasis. Pedal edema and ascites occur due to the hypoalbuminemia, may be seen in advanced illness. Mucosal lesions in mouth and nasopharynx seen in Sudan, rare in India. Hematological abnormalities occur due to bone marrow dysfunction, pancytopenia, anemia, leukopenia, and thrombocytopenia. Hypergammaglobulinemia due to polyclonal B cell activation. Leishmanoma, nodular skin lesions seen in African cases only. Secondary infections such as measles, pneumonia, tuberculosis, bacillary or amoebic dysentery, and gastroenteritis are common. Other findings include weight loss and hair changes, thinning, hyperpigmentation, etc. Death occurs due to superimposed infection, severe anemia, and hemorrhages. PKDA or the post-Kala Azar dermal leishmaniasis. PKDL is a non-ulcerative lesion of skin, occurs in 2 to 50% of the patients of visceral leishmaniasis following treatment with antimonials. It is aggravated by exposure to sunlight. Mainly seen in India and East African countries, it develops as hypopigmented macule near mouth which spreads to face, arms and trunks and finally becomes nodules resembling leprosy. In these figures, we can see the clinical features of leishmaniasis. Figure A shows splenomegaly seen in visceral leishmaniasis. Figure B shows hypopigmented skin changes in early PKDL. C and D show extensive facial nodular lesions in late PKDL. Now, ocular lesions like conjunctivitis and uveitis are associated in some patients. Sometimes PKDL may directly occur in subclinical patients without a history of VL. Diagnosis: by detection of mastocysts in the nodular lesions and by serological tests such as direct agglutination test DAT and antibodies to RK39 antigen, positive in most cases. PKDL in Indian subcontinent occurs in 2 to 20% of the VL cases, usually after 2 to 10 years and persists for a long period up to 20 years. It can affect any age group. Amphotericin B is the drug of choice given for 4 months. Leishmaniasis with HIV co-infection. Co-infection of HIV with VL has been reported from many countries. Southern Europe, France, Italy, Spain and Portugal account for majority of the co-infections, where 50 to 75% of VL and HIV are HIV positive and 7 to 17% of HIV infected people with fever have mastocysts. Okay. It is also reported from other places like Africa, Ethiopia, Sudan, Brazil, and India. In India, it is reported from Bihar, sub-Himalayan region, and other North Indian states. Both HIV and Leishmania affect each other's pathogenesis. Effect on HIV. Leishmania appears to cause activation of latent HIV. It expresses high level of chemokine receptors CCR5 on macrophages. Effect on Leishmania. HIV causes activation of Th2 cells response leading to the disease progression. Clinical features in HIV co-infected patients, apart from the classical features of VL, other forms such as CL, MCL, PKDL, and atypical presentations such as chronic diarrhea and pleural effusion may be observed. Diagnosis. Antibody detection tests are usually negative. Amastigotes are demonstrated from unusual sites such as bronchoalveolar lavage fluid and buffy coat region of blood. Visceral Leishmaniasis. Lab diagnosis. A microscopy GIMSA staining detects LD bodies, that is macrophage filled with amastigote forms. Splenic aspiration most sensitive. Bone marrow aspiration most common specimen, because splenic aspiration can lead to uh, the bleeding of spleen, okay, and a splenic rupture. Now, lymph node aspiration, liver biopsy, peripheral blood smear in HIV infected people, and biopsy of various organs in HIV infected people. Culture detects promastigote useful for species identification and drug sensitivity testing. NNN medium, triple N medium, and Schindler's liquid medium. Antibody detection in serum, ELISA, IFA, and direct agglutination test. ICT using RK39 or RKE16 antigen. Antigen detection, carbohydrate antigen in the urine, latex agglutination test. Molecular method, PCR, real-time PCR detecting specific kinetoplast mitochondrial DNA. Leishmanian stain, a Montenegro test indicates good CMI, DTH reaction, positive in all stages except active VL and diffuse CL. Okay. Animal inoculation, golden hamster, a non-specific test to detect hypergammaglobulinemia by Napier's aldehyde test and Chopra's antibody test, and pancytopenia by complete blood count. Lab diagnosis. In an endemic area, any case presented with fever more than 2 weeks, splenomegaly and or weight loss is suspected of having VL and should be subjected to laboratory confirmation. In this figure, we can see the Leishmania donovani amastigote showing a macrophage containing multiple Leishmania amastigotes. A shows a schematic diagram while B in the bone marrow smear stained with GIMSA. Note that each amastigote has a nucleus and a rod-shaped kinetoplast. Microscopy. Demonstration of amastigotes inside the macrophages, also known as Leishman-Donovan bodies or LD bodies, is the gold standard method for diagnosis of VL. Smear should be stained with Leishman or GIMSA or Wright stains. The various samples include splenic aspiration. The sensitivity of the splenic smear is excellent, but less preferred because of the risk of splenic puncture. Grading of LD bodies from splenic smear is useful in determining the parasitic load and monitoring the response to the treatment. Bone marrow aspiration is the most common specimen. Sensitivity is around 80 to 85%. Lymph node aspiration is useful only in African cases of VL and has low sensitivity, 53 to 65%. Liver biopsy less sensitive and carries the risk of hemorrhage. Peripheral blood smear made from buffy coat area after blood is centrifuged are particularly useful in HIV patients. Amastigotes are found within mononuclear cells and neutrophils. Biopsy specimen of various organs like oropharynx, stomach, or intestine useful in patients with AIDS. Culture. Useful specimens are aspirations from spleen, bone marrow, and buffy coat. Triple N medium, Novi, McNeil, and Nicole medium is the culture medium of choice. Schindler's Drosophila insect medium can also be used alternatively. Inoculated specimens are incubated at ambient temperature 24 to 26 degrees Celsius and examined weekly for 4 weeks before declared as negative. Amastigote transform into promastigote in the culture fluid, which are detected by staining with GIMSA stain. In these figures, 35A and B, uh, smear made from culture fluid shows promastigote forms in GIMSA stain, and in figure B we can see the triple N medium. The culture is found to be positive in 75% of the cases, and the culture is useful for specimen identification and drug sensitivity testing. Antibody detection in serum. In general, the serological tests are sensitive but less specific. False positive results may occur due to the cross-reacting antibodies in patients with leprosy, Chagas disease, CL, and other infections. Antibodies cannot differentiate current and past infection. More so, antibodies may be absent or present in low titer in patients with AIDS. Direct agglutination test, DAT. Serial dilution of the patient's serum is added with stained extract of L. donovani amastigote on microtiter plate and incubated for 18 hours. If specific antibodies are present, agglutination mat formation is visible by naked eyes. Button formation indicates the absence of antibodies. In this figure, we can see the direct agglutination test, the mat formation shown in blue, while the button formation shown in white. It is found to be 100% sensitive and specific. It is simple, rapid, and does not need any instrument. Disadvantage, however, antibodies persist up to years after the treatment. Immunochromatographic test ICT, it detects leishmanial antibody by using L-Chagas recombinant kinesin antigen RK39. It claims 100% sensitivity and 98% specificity. However, the sensitivity is low in East Africa and in HIV patients. Like that, it is also simple, rapid, and does not need any instrument, useful in field studies. Recently, ICT based on another novel antigen RKE16 from Leishmania donovani has been developed. Other tests available are ELISA and indirect fluorescence antibody IFA test. Antigen detection. Recently, latex agglutination test has been available detecting a heat stable, low molecular weight carbohydrate antigen in the urine of VL patients. It has good specificity but variable sensitivity 40 to 80%. Antigen detection is more useful in HIV VL co-infection as a prognostic marker indicating the active infection. Molecular methods, various formats such as PCR, nested PCR, and quantitative detection by real-time PCR are available targeting Leishmania-specific kinetoplast mitochondrial DNA. It is mostly confined to the reference laboratories with sensitivity varying from 70 to 93%. Leishmanian test, Montenegro test. It is a skin test to detect delayed hypersensitivity to a suspension of killed Leishmania donovani promastigote injected intradermally. Positive test in duration of more than 5 mm in 72 hours indicates a prior exposure of Leishmania antigens. Therefore, it is useful for epidemiological survey to estimate the burden of the disease. It is positive in people with good CMI, asymptomatic individuals, cutaneous leishmaniasis, and after recovery from VL and leishmaniasis receive deviance. However, this test is negative when CMI is low, such as in case of active VL and diffuse CL. Animal inoculation. Intranasal inoculation of specimens to golden hamsters yields mastigotes after several months. It is not in use nowadays. Non-specific test. Complete blood count to detect pancytopenia and elevated liver enzymes. Reversal of albumin globulin ratio reflects hypergamma-globulinemia. Other non-specific tests such as Napier's aldehyde test and Chopra's antimony test were in use in the past to detect hypergamma-globulinemia, now not in use. Treatment of visceral leishmaniasis. The various drugs used in treatment of visceral leishmaniasis are pentavalent antimonials, liposomal amphotericin B, miltefosine, and paromomycin. The WHO recommended regime used for the treatment is given in the table. Pentavalent antimonials. It has been the drug of choice and widely used in the past for several decades. However, as a resistance has been emerged, currently it is used in restricted to regions where the resistance has not been developed. Dosage is given 20 mg per kg per day, IM or IV for 30 days. Mechanism of action is converted to active trivalent form in body, reduces oxidative stress in the parasite. Induces oxidative stress in the parasite. Resistance to antimonials has been reported mostly from Bihar, India. Now, liposomal amphotericin B has been the current drug of choice in leishmaniasis, especially in areas where resistance to antimonials have been reported. Dosage is given 3 to 5 mg per kg per daily dose by IV infusion for 3 to 5 days up to total dose of 15 mg per kg. Mechanism of action acts by disrupting the cell membrane by forming pores. Miltefosine dosage is given 150 mg per day orally for 28 days. Mechanism of action by interacting with lipids, inhibiting cytochrome C oxidase. Resistance to miltefosine is rare, mainly reported from India and Nepal. Paromomycin is an aminoglycoside antibiotic with anti-leishmanial activity. It is given IM at a dose of 15 mg per kg for 21 days. Immunotherapy. Interferon gamma has been used in antimonial resistant and in selected relapse cases from Kenya, Brazil, and India. Now, finally, the prevention of VL, National Vector-Borne Disease Control Program, NVBDCP, is a national program in India which works for the control of 6 common vector-borne diseases in India. It has launched the Accelerated Plan for Kala Azar Elimination in 2017. The target for elimination is to reduce the annual incidence of Kala Azar to less than 1 per 10,000 populations at block PHC level. The blocks in the endemic area of India are classified into 4 categories based on annual incidence of Kala Azar. Each category has a specific action plan aiming towards Kala Azar elimination. as described. Now, the WHO recommendation in region of Indian subcontinent, the regime are liposomal amphotericin B, combinations of liposomal amphotericin B plus miltefosine, liposomal amphotericin B plus paromomycin, and miltefosine plus paromomycin. Amphotericin B deoxycholate, miltefosine, paromomycin, or pentavalent antimonials. In East Africa and Yemen, drug regime is pentavalent antimonials plus paromomycin. In Mediterranean Basin, Middle East, Central Asia, and in America due to Leishmania infantum, the drug regime is liposomal amphotericin B. Now, the categorization of blocks in endemic area of India based on annual incidence of Kala Azan 2014. Category 1, 94 blocks above elimination threshold, high transmission areas, annual incidence more than 1 case per 10,000 population. Measures to be taken: intensive care detection, vector control activities, case based surveillance. Category 2nd, 23 blocks with borderline endemicity with annual incidence 0.8 to less than 1 per 1 lakh population, low transmission area. Measures to be taken: requires NI surveillance. Category 3rd, 290 fluctuation blocks with increasing or decreasing trend either year to year or with a gap of few years. Measures to be taken are the operation factors to be looked in. And category 4, 207 blocks, silent blocks, that is cases reporting areas reporting nil cases annually for the last 2 consecutive years. Robust surveillance for validation of nil status is required and preparedness for the detection if cases occur. Vaccine trials: currently no vaccine is available for the prevention of leishmaniasis. However, the several trials are ongoing. Control measures: vector control measures should be followed, such as personal prophylaxis by using insect repellents or bed nets, control of canine or rodents reservoir. Phlebotomus does not fly high above the ground level and is not nocturnal habitat, so sleeping at the top floors can prevent transmission. Early treatment of all cases, mainly anthroponotic VL and PKDL cases. Okay, so this completes Leishmania. Now come on to Trypanosomiasis. Trypanosomes are hemoflagellates that reside in the peripheral blood and tissues of the host. Based on the geographical distribution, they can be classified into 2 types. African trypanosomes, Trypanosoma brucei complex, are transmitted by the vector CC fly, can cause African sleeping sickness. American trypanosomes, Trypanosoma cruzi, which is causative agents of Chagas disease and transmitted by insect vector radiovid bug, also called as triatomine bug. Chagas disease, Trypanosoma cruzi. Trypanosoma cruzi is the causative agent of South American trypanosomiasis or Chagas disease, named after the discoverer Carolus Chagas. Epidemiology: Chagas disease is mainly restricted to South and Central American countries like Brazil, Argentina, Venezuela, etc. Currently, it is estimated that 16 to 18 million people are infected with Trypanosoma cruzi. Annual incidence is around 2 lakh new cases with 50,000 deaths. It is a zoonotic disease having many animal reservoirs like dogs and cats. Life cycle: Trypanosoma cruzi is transmitted to man by rubbing of the vector radiovid bug's feces or abraded skin. Human cycle: the trypomastigotes from the bite wound are carried to various tissues where they transform into amastigote forms. Amastigote multiply actively. They are the intracellular forms found in tissues such as reticuloendothelial cells, spleen, liver, lymph node, and bone marrow, muscles, cardiac, skeletal, and GIT, and nervous tissues. Mastigotes transform back to trypomastigote forms, which are motile, C-shaped, non-multiplying extracellular forms found in peripheral blood as long, slender, or invasive forms and short, stubby forms. Invasive forms migrate to many organs, and short, stubby forms are ingested by radiovid bugs during blood meal. Vector cycle: in the gut of the radiovid bugs, the trypomastigotes transform into epimastigotes, which further develop into metacyclic trypomastigotes in the hindgut and are excreted in the bug's feces. Pathogenesis and clinical features: Chagas disease occurs in 4 stages. Early stage disease characterized by cutaneous and ocular manifestations. Chagoma forms a painful subcutaneous nodule at the site of deposition of bug's feces, commonly seen on face. Romana's sign: it causes unilateral painless edema of the eyelid and conjunctivitis. Acute Chagas disease: about 1% of the patients progress to acute stage disease characterized by fever, hepatosplenomegaly, and lymphadenopathy. Indeterminate stage is the asymptomatic phase lasting for years to decades before progressing into symptomatic chronic stage. Chronic Chagas disease: the parasite multiplies in the muscles, cardiac and GIT, and nervous tissue, producing various types of manifestations. Cardiac form occurs in 30% of the patients Patient develop dilated cardiomyopathy, rhythm disturbances, and thromboembolism. Gastrointestinal forms, for example, megaesophagus and megacolon. Autoimmune hypothesis, Trypanosoma cruzi antigens cross-react with mammalian antigens, molecular mimicry, producing autoantibodies which may be responsible for tissue injury seen in the chronic Chagas disease. Immune response, CMI to be particular, antibody-dependent cell cytotoxicity, ADCC is the mainly involved in tissue destruction in the chronic stage such as cardiomyopathy and megacolon. HIV and HTLV second, HIV and human T lymphotrophic virus HTLV second infected people are at a greater risk of reactivation of underlying Trypanosoma cruzi infection. Congenital trypanosomiasis. Rarely, Trypanosoma cruzi can be transmitted transplacentally both in the acute and chronic stage of the disease. It manifests as low birth weight, stillbirth, rarely myocarditis, and neurological alterations. Lab diagnosis, peripheral blood microscopy. In acute Chagas disease, the trypomastigotes are frequently found in peripheral blood, which can be detected by wet mount preparation and thick and thin smear examination. Blood concentration techniques like microhematocrit method may be employed if the parasitic count is low. Thick smear is more sensitive in detecting the trypomastigotes, whereas the thin smear helps in detailed study of its morphology. Trypomastigote forms of Trypanosoma cruzi measure up to 20 micrometer in size, C-shaped with large terminal kinetoplast with short, blunt posterior end. On wet mount examination, the motility can be demonstrated. Other diagnostic methods, blood is inoculated to triple N medium for culture or Jager's liver infusion tryptose medium, incubated at 25 degrees Celsius and observed for the presence of epimastigote forms. In this figure, we can see the Trypanosoma cruzi. Figure A shows the trypomastigote form. Figure B shows trypomastigote form in the blood smear stained with Giemsa, and C shows epimastigotes from the triple N medium culture. Antibody detection. Chronic Chagas disease is diagnosed by the detection of specific IgG antibodies by methods such as ELISA, Western blot, and Chagas RIPA, radioimmunoprecipitation assay. Antigen detection. Trypanosoma cruzi specific antigens from serum and urine of the infected patients are detected by ELISA, which are very useful for diagnosing acute and congenital infections. Molecular methods. PCR is available that detects Trypanosoma cruzi specific kinetoplast or nuclear DNA in blood. It is more sensitive than microscopy and serology for the diagnosis of chronic disease. It is also useful in monitoring the response to treatment and for the diagnosis of congenital infections. Animal inoculation by intraperitoneal inoculation of blood or CSF into mice. Xenodiagnostic infected patients are exposed to the laboratory maintain uninfected ready with bugs, and after 1 to 3 months the feces of the insects are examined by microscopy for the presence of the epimastigote forms. Now coming on to Chagas disease treatment. Therapy for Chagas disease is still unsatisfactory in acute disease. Benzimidazole is considered as a drug of choice in Latin America. Nifurtimox or allopurinol is given alternatively. For chronic disease, these lack efficacy and may cause many side effects. Supportive treatments such as pacemakers to manage the arrhythmias and surgery for the correction of megaesophagus and megacolon may be useful. Prophylaxis prevention of the disease in endemic countries depends on the control of vector. This includes residual insecticides, health education, measures to reduce insect exposure, and housing improvement. Now coming on to African sleeping sickness. Trypanosoma brucei was named after Sir Bruce in 1909, proved that disease is transmitted by CC fly. Trypanosoma brucei complex consists of 3 subspecies, out of which only 2 cause human disease. Trypanosoma brucei gambians, agent of West African sleeping sickness. Trypanosoma brucei rhodesiensis, agent of East African sleeping sickness. Trypanosoma brucei causes Nagana, or disease affecting cattle in Africa. It does not infect humans. Epidemiology. African trypanosomiasis is endemic in 36 countries of Africa with 60 million population at risk. Approximately 50,000 new cases occur annually. Life cycle. Trypanosoma brucei is transmitted to man by the bite of vector CC fly genus Glossinia. Inoculating the infective form, metacyclic trypomastigote forms into the skin. Human cycle. At the site of inoculation, they transform into long, slender trypomastigote forms which multiply by binary fission. Subsequently, they transform into non-dividing, short, stumpy trypomastigote forms which either invade the bloodstream and migrate to various organs or ingested by the CC fly during a blood meal. Vector cycle, short stumpy tripomastogote forms become long slender forms, then to epimastogote forms, and finally develop into metacyclic tripomastogote forms, which are the infective forms to man. Antigenic variation. Tripomastogotes undergo periodic antigen variation, leading to frequent change of antigenic nature of variable surface glycoprotein VSG antigens present on their surface. This serves as the key mechanism of evading host immune humoral response. Pathogenesis and clinical feature. In general, Trypanosoma brucei gambians develop a chronic course with slow progression, whereas Trypanosoma brucei rhodiens runs an acute course with a rapid progression and early death. Stage 1 disease, hemolymphatic stage. Trypanosomal chancre, it's a self-limited lesion that appears a week after the bite of an infected CC fly. Asymptomatic period. Following this, the clinical course runs through an asymptomatic phase which lasts for a few months. Systemic febrile illness. Months to years later, systemic febrile illness develops due to the dissemination of the parasite through the lymphatics and bloodstream. It is characterized by remittent irregular fever with night sweats, lymphadenopathy. The posterior cervical nodes are commonly involved, called as Winterbottom sign. Its consistent feature of West African trypanosomiasis. Stage 2 disease, the CNS invasion. It involves invasion of the CNS, which leads to progressive chronic meningoencephalitis. Patients develop characteristic daytime somnolence caused by sleeping sickness, with restlessness and insomnia at night. Trypanosoma brucei gambians differs from Trypanosoma brucei rhodiens in several ways. Lab diagnosis, direct microscopy. Useful samples are multiple blood samples collected during the febrile period, chancre fluid, CSF, lymph node, and bone marrow aspirate. Blood examination. Tripomastogote forms are seen by serial blood sample examination, which is performed either by wet mouth examination, peripheral blood examination by thin and thick smear, concentration methods such as microhematocrit centrifugation if parasitemia is low. Tripomastogotes of Trypanosoma brucei. Tripomastogotes are elongated, 14 to 33 micrometer long, having a flagellum with undulating membrane. Cytoplasm stains pale blue, containing dark blue granules with nucleus staining red. Now, comparison between Trypanosoma brucei gambians and Trypanosoma brucei rhodiensis. Disease. Gambians cause West African sleeping sickness. Its vector is CC fly Glossinia palpalis group. Primary reservoir is human. Human illness is chronic central nervous system CNS disease. Duration is from months to years. Lymphadenopathy is frequent. Cervical lymphadenopathy with Winterbottom sign. Virulence is less as the parasitemia is low, and rodent inoculation is not useful, while the drug of choice for stage 1 is pentamidine, for stage 2 is eflornithine. Now for Trypanosoma brucei rhodiensis, which causes East African sleeping sickness, the vector are CC flies Glossinia morsitans group. Primary reservoir are animals like antelopes and cattle. Human illness is acute early CNS disease up to 9 months. Duration of illness is less than 9 months. Before that, death occurs. Lymphadenopathy is minimal, axillary and inguinal. Virulence is more as the parasitemia is high, and rodent inoculation is diagnostic, while the drug of choice for stage 1 is suramin, or stage 2 is melarsoprol. In this figure, we can see the tripomastogote form of Trypanosoma brucei in peripheral blood smear examination of Giemsa stain. A shows thin smear, while B shows thick smear. Now, CSF examination is necessary to confirm the CNS invasion either by detection of tripomastogotes in CSF or by WBC count more than 20 cells per microliter of CSF with parasite detected in blood or lymph node aspirate. Lymph node aspirate is useful for Trypanosoma brucei gambians and shows variable sensitivity of 40 to 80%. Antigen from serum and CSF. Antigen detection by ELISA in serum or CSF is useful for clinical staging of the disease, to determine CNS infection, and for monitoring the response to treatment. Antigens are rapidly cleared following improvement. Antibodies from serum and CSF. Card agglutination test for trypanosomes CATT. It detects antibodies to VSG antigen. Semi-quantitative ELISA using VSG antigen of Trypanosoma brucei gambians is available to detect various antibodies in serum and CSF. Molecular methods. PCR assays have been developed which show a high sensitivity with a detection limit of 5 parasites per ml. Fish fluorescence in situ hybridization using peptide nucleic acid probe appears to be an excellent diagnostic tool with detection limit same as PCR. Culture samples can be inoculated into kiwi kit for in vitro isolation, and trypomastigotes are recovered in 7 to 10 days. However, culture is not routinely performed. Animal inoculation in mice, it's highly sensitive for isolation of Trypanosoma brucei but not useful for Trypanosoma brucei. Other non-specific findings: sustained high levels of IgM may be seen due to antigenic switching in the parasite. Absence of elevated IgM levels in serum in an immunocompetent host rules out trypanosomiasis. Treatment: African sleeping sickness. The drugs used for treatment of African sleeping sickness are pentamidine and suramin. Alternative drugs are eflornithine and organic arsenical melarsoprol. Treatment is based on the type of disease, West or East African, and presence or absence of CNS invasion. Prophylaxis: vector control strategies like destruction of the insect's habitat, elimination of reservoir sources, etc., can be done to control African trypanosomiasis. Vaccine is not available as the parasite undergoes frequent antigenic variations. Now coming on to the questions. A 31-year-old man from Bihar presented with splenomegaly, anemia and fever. The bone marrow aspirate collected was subjected to GIMSA, which revealed amastigotes filled within a macrophage. Clearly this is the case of visceral leishmaniasis. Okay. Now identify the etiological agent, about the life cycle, pathogenesis, diagnostic modalities and the treatment. All that we can write. Now, the short notes on post Kala Azar leishmaniasis, African sleeping sickness, and Chagas disease can be written. Now, coming on to MCQs, vector for leishmaniasis is of course sandfly. A mastigote form of Leishmania donovani resides in the cells of reticuloendothelial system. Leishmania donovani can be cultivated in triple N medium, while American trypanosomiasis or the Chagas disease is caused by Trypanosoma cruzi. Okay, so this completes the chapter. Next, we'll be starting with lymphatic filariasis. Okay, so like, share, subscribe. Thanks for watching.